Good afternoon, Mr. Chairman. Let me thank Dr. Ravi Gupta for giving me this opportunity. I am speaking on tibial pylon fracture. Tips and tricks for external fixation and plating. It's an intra-articular fracture of distal tibia, about 1% of lower limb fractures and about 10% of the tibial fractures, where the talus is acting like a hammer driving inside the distal articular surface. What are the different problems? Paucity of blood supply at this region. Most of the time it's a high energy fracture commonly associated with open wounds and finally results into the ankle stiffness. The mechanism is forced dorsal flexion of the ankle, forced axial load, fall from the height or motorcycle accidents. Anterior part of the talus is driven into the platform, which leads to the comminution. The injury is in the 4 stages. The first stage is a vertical medial malleus split. Second stage is a fracture of the anterior tibial articular surface because of the forced plantar flexion. Third is a fracture distal third of the fibula, and the last is an transverse fracture in supramalleolar region above the anterior lip of the fractures. So you must know all these 4 stages of the fracture so that it's easy to unfold this. Clinically, patient presents with a deformity, a severe soft tissue injury, restricted movements, loss of vertical height of the fibula, and painful ankle. The challenges are restoration of the articular anatomy to provide the chance of adequate ankle function, extensive soft tissue injury, and surgical fixation must heal without any complications. Classification, Thomas and Rudy was the first who gave us a good classification. However, I will not go into the details because we are going to talk on tips and tricks. This was his type 2 and type 3. Type 3 was a highly displaced and comminuted fracture of the pylon. What is more important is to remember what is the pattern of injury. It's a rotational pattern where there is a minimal anterior comminution, 2 or more large fragments of the tibial anterior fragments, and transverse oblique fracture of the fibula. Whereas what is more common is a compression type of fracture where there is a marked anterior tibial comminution, superior migration of the talus and narrowing of the ankle joint, and secondary severe axial compression. It is the restricting to the external fixator, a lag screw with an external fixator, open reduction, interaction by plating. Open reduction, once the swelling has reduced, general principles used are restoration of the length of the limb, reconstruction of the articular surface, bone graft. Open reduction and internal fixation with plate has given excellent result for this difficult fracture in the experienced hand, and lately most of us have started doing plating after the subsidence of swelling and the soft tissue. Either you use a tubular plate, 1/3 tubular plate for the fibula, and tibia is but different types of it. It can be anatomical plates also, along with grafting could primary, word, or it can be considered after maybe 3 to 4 weeks. The rationally augmented fixation of key articular fragments, respect for all soft tissues, restoration of the length by plating, or in case there is a transverse fracture of fibula by nailing, articular surface congruity, bone grafting either early or late, and anteromedial external fixator for complementation of definite internal fixation. You could have a limited internal fixation by either lag screw or at times multiple K-wires, no vigorous dissection. It's a percutaneous fixation. This is one of the example, not badly displaced, but it could be easily reduced, stabilized by limited internal fixation. Another patient, badly comminuted, but articular surface is well maintained, good alignment after the fibula, and external fixator as a definitive treatment for this particular fracture. Another very bad C type of fracture, treated by external fixator and limited union of fracture is seen, final exercise after 15 months, showing a varus angulation at the fracture site. External fixation is done on the principles of ligamentotaxis, distraction to maintain the axial length, limited internal fixation by lag screws, a minimal intervention. It can be with or without screw. A lateral pitting of the fibula may also be added to buttress the lateral area. External fixation could be either extra-articular or supplementary by K-wire. This is one of the treated by external fixation and lateral fibular plate fixation. This is another example immediately after fixation, and this is 13 months after healing of fractures. This is the way we take up the patient under spinal anesthesia, regional anesthesia, reduce under image intensifier, do a multiple K-wire fixation, and reduce the axial length by external fixator. And this is at the end of about 6 months. Open reduction and fixation is done after the swelling is reduced and wrinkle sign has appeared. Initially it might be treated by elevation or temporary external fixator. This is one of the example preoperative X-ray showing accommodated fracture treated by primary osteosynthesis by fibular fixation by nail and tibial fixation by intermedial plating. Another fracture similarly treated by open reduction, anteromedial plate and rush nail for the fibular fixation. The basic principle is you should have a diagrammatic representation. Fix the fibula first by a plate, then reduce the fracture, do a multiple K-wire fixation, stabilize, confirm under image intensifier, and then put a plate medially and anteriorly and supplementary bone graft in the void. This is the same patient treated. Pylon fracture can be treated initially by external fixator and subsequently by plate. External fixation could be with the help of, for example, showing a final. The definite role of after reconstruction, there is a metaphyseal defect and void examination to achieve necessary to do a bone grafting. It adds to the mechanical and biological strength to achieve. Once extensive damage, degenerative changes has taken place, realignment will not offer any relief and ankle fusion would be necessary. The peculiarities of this fracture is its intra-articular injury, crossly comminuted, metaphyseal defect and void, and late deformity and arthritis is very common. Presently, no study has defined any criteria or window of opportunity for reconstruction which are alternative to the fusion. So what is the treatment? Limited internal fixation by fibular plating, latch screw, multiple K-wires and bone grafting, or open reduction and internal fixation. External fixation with limited internal fixation on these bulbs. Frequent outcome, there could be subchondral collapse, primary or late, and his bone grafting, primary or secondary, should be considered if there is a void. So in conclusion, stable fixation means open reduction, internal fixation, restore articular quality, fibular plating to maintain the length, and bone grafting to avoid collapse. This is what we published last year by Trauma Society of India, Thimes publication,